Transparency for hospitals and it's not new to Ohio. There have been proposed bills, reintroduced bills, even bills passed in the state Senate.
The number on that hospital bill is not real. It was never meant to be real. And once you understand how hospital pricing actually works, you will never look at American healthcare the same way again. Every single day, millions of Americans receive medical bills for amounts they could never afford to pay. A patient walks into an emergency room with chest pain, spends 6 hours being monitored, and walks out with a bill for $47,000. That bill is not a mistake, and it is not random. It is the product of a system deliberately engineered to produce numbers like that. Her name does not matter, but her story does. She was a 43-year-old teacher in Ohio, insured, employed, and careful with her finances. After a 2-night hospital stay for a gallbladder removal, she received a bill listing her total charges at $89,000. Her insurance company had negotiated that number down to $11,000, and she owed $3,000 out of pocket. But the question nobody asked her, and the question almost no one asks, is where did $89,000 come from in the first place? That original number, the one printed at the top of her bill, is called the chargemaster rate, and it is one of the most powerful and least understood tools in American healthcare finance. Every hospital in the United States maintains a master list of prices for every single service, procedure, supply, and medication they provide. This list is called the chargemaster, and it is set entirely by the hospital, with no government regulation, no standardized formula, and no requirement that it reflects actual cost. A single aspirin tablet might be listed at $15 on a hospital chargemaster, while that same aspirin costs 3 cents at a pharmacy down the street. The chargemaster is essentially a fantasy price list, inflated to a level that no individual patient could ever fully pay. It exists not as a reflection of value, but as a negotiating anchor, a starting point from which insurance companies can claim massive discounts. The bigger the original number, the more impressive the insurance company looks when it tells its customers it negotiated the price down by 70%. Here is where the system becomes deeply intertwined with financial incentives. Insurance companies negotiate directly with hospitals using the chargemaster as their baseline, and in exchange for bringing large volumes of insured patients to that hospital, they receive steep contractual discounts. These negotiated rates are kept confidential through non-disclosure agreements, meaning that even 2 patients sitting in the same hospital room on the same night may be paying completely different amounts for the exact same care. The patient without insurance, however, is handed the full chargemaster rate, or something very close to it. They have no negotiating army behind them, no contract, no leverage. They are the only participant in this system who is expected to pay the original inflated number, which is precisely why medical debt is the leading cause of personal bankruptcy in the United States. In 2021, the federal government passed a hospital price transparency rule requiring hospitals to publicly post their prices online. Compliance has been slow, inconsistent, and widely criticized by health policy experts. A study published in Health Affairs found that more than 65% of hospitals were still not fully compliant years after the rule took effect. And those that did post prices often buried the data in formats so complex that the average person could not interpret them. The opacity is not accidental. Transparency would allow patients to compare prices, would give employers and insurers stronger negotiating leverage, and would expose the extraordinary variation in what different hospitals charge for identical procedures. An MRI of the knee, for example, it can cost anywhere from $500 to over $10,000 depending on the facility, even within the same city. There is no clinical difference. There is only a pricing difference, and that difference is worth billions of dollars annually to the hospital industry. The hospital industry in the United States generates over $1 trillion in revenue every year. The largest hospital systems have operating margins that rival Fortune 500 corporations, and their executives earn compensation packages in the millions. Between 2010 and 2020, the number of independent hospitals in America declined sharply, absorbed into massive health systems that now control pricing across entire regional markets, reducing competition and giving them even greater leverage over insurers and patients alike. Nonprofit hospitals, which make up more than half of all American hospitals, receive billions of dollars in federal tax exemptions every year in exchange for providing charitable care to the community. But a 2021 investigation by the Loan Institute found that 80% of nonprofit hospitals took in more in tax breaks than they gave back in charity care. Some of the most financially powerful hospital systems in the country are legally classified as nonprofits, meaning they pay no federal income tax while generating hundreds of millions in annual surplus revenue. Pharmaceutical companies supply medications at one price to hospitals. Hospitals charge patients at a dramatically marked up price, and the difference, called the drug margin, is treated as a revenue stream, not a medical service. Facility fees, a charge simply for walking through the door of a hospital-affiliated clinic, have exploded in the last decade, with patients being billed hundreds of dollars for appointments they believe would cost a simple copay. Every layer of this system, from the chargemaster to the facility fee to the confidential insurance contract, is a mechanism designed to extract maximum revenue while maintaining enough complexity that most patients cannot understand what they are actually being charged for. And this is the deeper truth that the system depends on. It depends on confusion. It depends on the average patient being too overwhelmed, too frightened, or too sick to question the numbers on their bill. It depends on the assumption that most people will pay what they are told, or will simply avoid care altogether to escape the financial risk, and it which produces its own devastating public health consequences. The hidden pricing system inside American hospitals is not a flaw in the system. It is the system. The chargemaster exists to create the illusion of savings. The confidential contracts exist to prevent comparison. The billing complexity exists to discourage appeal. And the consolidation of hospital networks exists to eliminate the competition that might otherwise force prices down. Every architectural choice in this industry points in the same direction, away from the patient and toward the revenue cycle. If this video opened your eyes to how hospital pricing actually works, please take a second to like it, because that helps this kind of investigative content reach more people who need to hear it. Hey, subscribe to the Medical Money Machine if you want to keep pulling back the curtain on the business of American healthcare. And drop a comment below telling us whether you have ever received a medical bill that shocked you, because those stories matter, and this channel is here to tell them.